Thank you, the organizers, for inviting me and also for the kind introduction. So from growth, we'll switch over to the diabetes. Before going to my presentation, I must say that while I am in Kolkata, I feel pretty much at home, because the only place other than Bangladesh I can speak in Bangla. So a very good afternoon to you all and Shubha Apuranno. So I will proceed because I know it's very short of time. So 25 minutes is allocated, dear chair, yes. So this is our nature of Bangladesh, the beautiful nature. So we'll switch over to diabetes now. So diabetes care. And we know that the Ibrahim model, who is Professor Ibrahim, founded the Diabetic Association of Bangladesh in 1956. And the journey is still going on. The access in Bangladesh is mostly through Diabetic Association, through the affiliated association throughout the country. And actually it is the extended hand of the government, we should say. And it is the largest non-profit healthcare network. 3.5 million patients are registered under our association. And currently looking after only 30% of all people with diabetes in Bangladesh. And we are hoping to cover 50% by next year. So diabetes care for children. So we established the pediatric department in 1997. And currently we have an outpatient comprehensive care which has been started since 2010 in Burdem. I can see the we know that we need comprehensive care for children to manage, because not only the doctor, you should have all the healthcare professionals under one single roof, that is a dietitian and psychologist and social worker, and also the main is health educator as well. So we also have established diabetes daycare, because you can understand we have only one large hospital which is taking the diabetes care, so we have lots of patients who wants the admission. So sometimes we give the daycare only to the new patients or only the patients who are coming with acetone. And we have introduced insulin pump. For the last 2 years we are running in the same center. And we have complication assessment service as well. This is also very important, because we are looking patients like more than 10, 20 years. So we know according to ISPAE guideline, we should start the screening after 2 years, or during the puberty, we should start the complication as well. So currently, more than 6,000 children, adolescents, and young adults are registered in our center. So this is the main center we are having in Dhaka. And also we are trying to establish 2 centers in the southern part, so that is here and also here. But we are working also with the government that we should start some one comprehensive care in the northern side, because we have lots of patients from northern side of Bangladesh. So the challenges is quite similar. The challenges that is, other than the financial challenges, we also have lots of social challenges like India are having. So also the long distance, because though we have the peripheral centers, we can't establish all the comprehensive care in those peripheral centers. The long distance is sometimes a problem, that patient doesn't come or drop out is there. And education, lack of education, of course, because there are lots of false beliefs and myths, like it's an infectious communicable disease or something like, and hiding diabetes because of the fear of bullying. And familial disharmonies, social barriers, especially for girls, because they find that difficulty in marriage is another challenge. So now the epidemiology, actually there is no specific or confirmed data about the epidemiology. The estimated data from the IDF Atlas is that maybe there are more than 17,000 patients with type 1 diabetes, 3.4 cases per 100,000. In our clinic, we have around 600 new patients registered every year. And around 1/3, unfortunately, are diagnosed and getting care under LFAC and CDIC project. We are not sure about others. Maybe they are undiagnosed. So this is the trend. We can see how the rising of type 1 diabetes in our clinic. So we did a study where we found that we look into our data, retrospective data, and we found that the annual incidence per 100,000 was 1.24 for less than 15 years and 0.96 for more than actually 15 years it will be. The 10 to 14-year age group showed a higher incidence, but peak type 1 diabetes onset is at the age of 15 years later than in developed nations. It was done in 2017. The total number of patients was 2,347. Another data we can see that how it is the rising trend in the less than 15 years. Here we can see that again that this age group is more vulnerable of where their diagnosis as type 1. And if you look into the seasonal peak, that's very interesting that during the winter season we are having more than the summer. We are not sure why. Maybe there are viral or infections, something provoking the blood sugar level, and the diagnosis is there. Interestingly, type 2 is also rising in our clinic. If we look back, 10 years back, we were fighting with the undernutrition, but overnutrition is another burden now, and we can see how there is rising of type 2 diabetes in our population. Now the clinical findings, what we are having. So the peak age group was in 2012 was 10 to 14. Sorry. Yeah. And in 2017 also we can see the same trend that the adolescents are diagnosed as type 1 mostly. If you look into this data, we can see that that less than 5 years is very low, they are diagnosed. 6 to 12 years, a little higher, and mostly is the 12 to 18 years, though they are diagnosed at this age group. And less than 25 years also they are having diagnosed, and also more than 25 years they are diagnosed with type 1. So at the end of the day we can see that mostly they are diagnosed as this age group. This is the latest data we are having with the sweet registry. Now the types. The types of diabetes, if we look into the types, of course we got type 1 mostly. In 2011 we did a study, and you can see in 329 total patients we had mostly type 1. Also the second most common was in our clinic fibrocalculous pancreatic diabetes. Only we had one type 2 at that time, and others were there. But if you look into the latest data in 2017, we found that the very less common of FCPD has gone down, and type 2 is rising, and type 1 is as before. And some neonatal diabetes is there, very little. So this is the latest data in 2018. We can see that again type 2 has become going up. That is the new patients who are diagnosed, 10% are now, there was type 2 in 2018 data. And in 2019, most alarming, I should say that the type 2 is more rising, that is more, 16% were diagnosed as type 2 in 2019. And others were 9%. So of course there are difficulties for the diagnosis, because children with type 1 diabetes are now becoming overweight or obese at presentation, sometimes confusing whether they are type 2 or not. Children with type 2 may have typical presentation as well, indistinguishable from those with type 1. Majority of our patients have typical symptoms but do not have ketosis frequently. Actually, around 10% only present with DKA. Type 2 diabetes very rarely have ketosis. So these are the difficulties sometimes as a clinician we have during the diagnosis or typing of diabetes. So we did a research recently, it has just published this month. You can look into, because we have a very interesting data, I should say, that the title was Clinical Features, Biochemistry and HLA DRB Status. If we look into the data, we can see that type 1 diabetes age group is, as we have seen, the type 2 is almost similar, and FCPD was a little higher. BMI was higher in type 2, of course, type 1 was less. And HbA1c, we can see that high was in type 1 diabetes, of course, but in case of type 2, the diagnosis HbA1c is not that very high. And C-peptide level, yes, you can see that the normal level was not present in any of the type 1 diabetes, but a little normal was found in almost 84% of type 1 diabetes during presentation. And in case of type 2, yes, normal level was 100%. And regarding the antibody test, autoantibody test, we can see that only around 20% patients were positive, GAD and IA2 positive was only 10%. So mostly we are having autoantibody negative type 1 diabetes, though we just did the 2 of the antibodies in this study. And that diabetic, if we related with the diabetic ketoacidosis, with the C-peptide, we can say that some normal, those who are having normal C-peptide had presented with mostly with DKA. So treatment modality in our patients, we can see that most of the patients now having multiple daily injections, because this is another problem we found, because the mid-time, that is, injection is very difficult in our setup also, because we don't have school educator or nurse or even space to give insulin, but we are trying to motivate. Sometimes we do the school programs as well to establish this. So MDI is now more common in our clinic, though it was not 10 years back. We usually used to go with the twice daily regimens. Regarding the pump experience is very new in our clinic. We have now 35 patients on insulin pump with type 1 diabetes, and just a preliminary data that of 20 patients we can share that for the 6 months we got that BMI was pre-pump and post-pump same, insulin dose was significantly reduced, HbA1c was reduced but it was not very significant, but there was very little complications like hypoglycemia or decay during pump. And these are the, I'm sure the pretty much that here also these are the, you can see the pump scenario, pre-pump, CGMS, you can see, so fluctuations of blood sugar we are having. And post CGMS we can see at least we can reduce the fluctuations of blood sugar levels. And the very important part is the metabolic control for which we are fighting for actually. And if we look into the trend from 2015 to 2019, we can see that at diagnosis it was very high, less than 1 year duration actually, it was high. And 2019 mean HbA1c is 9, and more than 1 year same 9, this HbA1c. And if we look into the age group, we can find this age group, they are having better HbA1c. That is, young adult group are having better HbA1c other than the young children or adolescents. So complications, we are having around, this is the data from 2010 to 2014. we got like 7% patients presented with DK, and we had cataract at that time more that presenting during diagnosis. Also, we can see the trend of DK reducing over the 6 years. And this is the very interesting data. This is actually with the SWEET benchmarking report. We can see that the presentation of the DKA was similar. And for last 2 years, it's almost rising with all the centers in the world, like they are also rising at this point. And we have this cataract. I have told that mostly in the fibrocalculous pancreatic diabetes, they are presenting with cataract. Regarding chronic complication, the complications we have mostly nephropathy or microalbuminuria in our children. And another study we did in 2012 to 2014, we in around 200 patients, and among them we had like 25% patient had microalbuminuria. And these microalbuminuria were more in the type 2 diabetes. And regarding retinopathy, yes, we are screening for that regularly, according to the ISPAE guidelines. Sometimes even earlier, if we found like not having very good glycemic status, we do the screening even some earlier. And we got 5.6% patients having retinopathy, but it was of course grade 1 retinopathy, and the total patient was 1227. We know that if we can diagnose earlier the grade 1, it is always reversible if we can have a good metabolic control or good blood pressure or cholesterol. We have another challenge, that is diabetes in special situations like Ramadan. I'm sure sometimes you also have here. And we did one study, and we found that majority of the patients could complete their fasting during Ramadan. The total patient was 33. Another study we did with the Ramadan patients, because our adolescents always insist on fasting during the Ramadan month. And we found that we took 74 patients who insisted, and mean age was 19.8 plus minus 3.4 years. And the result was there is no significant difference in the frequency of hypos between two groups, like those who have better control and those who have poor blood sugar control. And no decay was reported in either group, and there was significant reduction of HbA1c in both the groups. You can see how it went down. So this is also very important to do some activities, not only doing the blood sugar level and do the follow-up in the clinic, but also important to do some camps, awareness clinics. We usually do the camps and activities with our children and adolescents. Some of the pictures, also their achievement, you can see. So we can conclude that prevalence or incidence of diabetes in children in Bangladesh is rising. Also the type 2 is rising as well. Unavailability of comprehensive care, yes, with long distance to the main center is one of the major challenges of managing these children. And our population, female, are predominating with age of onset more at adolescent age and lesser at younger age group. And atypical type 1 diabetes maybe are common in our population, because we saw that autoantibody negative population are there. And metabolic control is improving in our Bangladeshi children and adolescents and young adults with comprehensive care. So long to go to make them happy, to ensure the better quality of lives in our children. I usually end with the painting of our patients. I like to do that because lots of our patients, they paint and bring them in during the follow-up in the clinic. And she is a patient with dermatomyositis. She had high dose of steroid, and actually we had to fight with the control of her blood sugar, because always it's like 18 to 20. And recently we have started the insulin pump, and with the regular insulin as well. And interestingly, her blood sugar level came down almost 5, 6, 7 at postprandial like 10 to 12. And her last HbA1c came down to 7.4%. So, and the painting she has done with her perception, I can tell that yes, it's difficult to manage the diabetes, but of course it's not impossible to live with it. That's all from me. Thank you very much for your patience hearing.